rapid evidence assessment of the literature. And I don't think we need to talk much about the relevance of this topic to this group. I can't imagine many topics more important than learning to increase our efficiency of thoroughly reviewing the literature on research topics that we're involved in or new topics. So just a brief introduction to Dr. Jonas. I know all of you know of him, but in looking over his bio, I'm always impressed with some of the some of the things that are new to me. As you know, he's President and Chief Executive Officer of the Samueli Institute. Of course, he's widely published. He is also practicing as a family physician. He's a professor of family medicine at Georgetown, adjunct faculty at the Uniformed Institute, University of Health Sciences, and a retired lieutenant colonel of the Medical Corps. We all know that he was previous director of the Office of Alternative Medicine, and greatly appreciate his work during that time. He has a lot of experience in CAM research on many of the CAM disciplines and modalities, including homeopathy, electroacupuncture, nutrition, and others. He's, of course, widely published in very high-quality journals. His current research interests include projects on information biology. I thought that was really interesting, and several other topics. And the impact of optimal healing environments in healthcare is also one of his interests, which I think fits in with our recent discussions of disciplines research. I think that ties in pretty well with some of the things we've been thinking about as a group. Ms. Crawford leads the Systematic Review Initiative at Samueli. And she's research manager there. She's an expert in literature search functionalities and systematic review methodology. She oversees and conducts 10 to 20 literature reviews on topics that relate directly to Samueli's research agenda. And she's developed this rapid evidence assessment of the literature called REAL, this REAL process that's implemented and taught at Samueli. And she's the author of more than 15 systematic reviews. So I'll get out of the way now and turn it over to Drs. Jonas and Ms. Crawford, who we're very honored and grateful to have here. Thank you very much, you two.
Excuse me, let me insert. This is John. We are recording, so you should know that. We caught you, Greg, too. Go ahead, Wayne and Cindy.
Okay, thank you very much, and it's a great honor to be here and to participate in this, and it's great to see this research group going and moving forward, and any way that we can help enhance this. I've had a long input and love for the CAM professional and education groups, and raising the activity and the knowledge and capacity on research in those groups, I think, is extremely important. The gaps of research and their utility are complex. There are multiple decision makers in healthcare, and they're all interested in different types of evidence. The reasons for that interest has less to do with the rigor of it as to the uses that they're going to make of that information or evidence to make decisions. And so we're actually doing an internal training today at our institute on something called a claims assessment profile, for example, which is a descriptive aspect around what the primary question is around the claim. And so often, and this is experienced extensively in the area of complementary and alternative medicine, or in traditional medicine where there's different paradigms and different frameworks and contexts in which things are being delivered, to know what makes up good evidence. And so for those of you that are interested in this in more detail, I'm happy to come back, and if we have a chance towards the end of this, this little presentation, to talk a little bit about are there ways we can work together to enhance the capacity in the the CAM professional groups would be more than happy to do that. There is a book that on clinical research in complementary medicine that is out that describes many of these things, such as strategies, methodologies in these areas by the lead editor is George Lewis, myself, and Harold Wallach, Clinical Research in Complementary Medicine, and I think that's a book I'd all suggest to you to look at for those of you that are particularly interested in that. And if Cindy doesn't say it, I will say it now. Cindy runs a series of systematic review and expert panel workshops and training series to help teach people how to use the methods that we're going to show you. One of the methods that we're going to show you today, and so that's something that might be of interest to your centers. And we do and go around and do those workshops at various universities and educational institutions. There's one coming up in February down at UCSD in collaboration with the Pacific College of Oriental Medicine. And there'll be some folks from Bastyr there helping out. And those are some examples. So we're very interested in providing that kind of interaction, training, and customization to those areas. So the goal of our presentation here today is to focus in on one area that is really at the heart of what's called evidence-based medicine. And it has to do with systematic review process. The systematic review process is a process that takes the current evidence and uses a structured, objective, and bias management system to come up with the most objective biopsy, if you will, of what do we know around any particular question in evidence in healthcare. And it's grown out of the need that primarily within the conventional field, because we discovered that the old sort of hierarchy of authority, meaning there was an expert that had a lot of experience, or a biologist that had a mechanistic explanation, or a company that was funding a new device or treatment or drug, that the evidence from those sources was not only frequently erroneous, but it was also harmful. That we were actually, in many cases, killing patients because we didn't provide good bias-free assessment. And practices would be adopted based on those kinds of influences rather on good science. And so that evolved largely starting in the 70s and has begun to be structured gradually in those ways. Now, as we all know, and as I'm sure you've discussed probably in your groups, that's not enough, but it at least has to be the starting point in the area of providing either evidence-based or evidence-informed medicine, and we can talk about what the difference is between those two things in a little bit. I'm sorry?
Can everyone see the slides?
Yes, can everyone hear us and see the slides? So we just want to check with the folks. If you're on GoToMeeting, you should be able to be viewing the slides at this point.
Yes.
They're
Yes.
there.
Okay, great. So I have no conflict or disclosure. Our training programs actually are funded by military research. We do training in the military, but they are specifically in the area of complementary and alternative medicine research training, and so outreach into non-military populations is something they're very happy to do. Just a little brief thing on the Institute. I think our goal is to create a flourishing society through the scientific exploration of wellness and whole person healing. We do that through research, through thought leadership and innovation, and through educational components. We work with individual information. We work a lot with the DoD and the Veterans Administration, that is where there's growing interest in these areas, and with systems like hospital systems, policy maker systems. And our goal is really to focus on salutogenesis, the flip side of pathogenesis. Pathogenesis is what we learn in medical school. It's the generation of illness, and then we find treatments that interfere with that. Salutogenesis is about health enhancement and stimulating and facilitating healing. So we're interested in that science in those particular areas. So I've gone over the importance of critical evaluation and the role of systematic review. And I would say this slide says there's no widely accepted institutionalized medicine. I think method for rigorous process. There are some growing methods that are more and more accepted, but I'll tell you there's not a complete standard for doing this, and the current methods tend to be very cumbersome and very expensive. I just got off of an Institute of Medicine panel where they attempted to do good literature reviews on chronic multi-symptom illness for veterans, and they were bringing together a variety of methods trying to train the experts in how to do that, and it cost a good $500,000 to run that panel. What Cindy and her team have done is that they have maintained the rigor of those approaches, but then streamlined and enhanced the objectivity in the process and the reliability of the process, and then computerized a number of components of it to markedly cut down the effort and the expense of doing systematic evaluation in a way that gets down into the cost ranges that a variety of groups can be involved in. And we have groups like Massage Therapy Association and other herbal groups and acupuncture groups who sometimes come and utilize these methods that she'll be talking to her about. Now, before she goes into the systematic review methods, I'd like to sort of give you a framework for thinking about research, integration, and synthesis that is an alternative to the hierarchy that is often used, for example, in the Cochrane collaboration and this type of thing, because I think it speaks to what you were just talking about in the mixed method components and provides a much more pragmatic approach without sacrificing for this type of thing. And it starts with the question. So if you look, for example, in the inner circle of this graphic I'm showing here now, there is a set of questions that are the most frequent questions that are asked about any medical system or any intervention. At the top of this circle, you'll see the first question is, what is it and how is it applied, and what do we know about it currently? After that, often people ask questions, what impact is it having in a particular setting? If I take this practice into a health organization that's outpatient, inpatient, community, how effective is it? A third set of questions is, how does it work, and is it safe and effective? This is our traditional mechanistic and efficacy questions. But then we need to know information about what are the costs, and how does it compare to other practices, because we're not faced in a vacuum. We have an alternative of selection, and we need to know how do various comparative practices exist. And then finally, how can it be translated into other settings in those particular areas? Now, each of these questions requires a different type of method. So at the top of the circle, you'll see the types of approach that's required to answer those questions. So what is it and how it applies requires more descriptive research. What impact is it having? It uses methods such as outcomes evaluation, prospective outcomes evaluation, or program evaluation. And mechanisms and validity uses randomized controlled trials, comparative effectiveness research, and then application research in those areas. And so if you fill in your sort of methodological matrix and match it to the questions in the regions that you're interested in answering those questions, we now have a very different way of determining what the gold standard is in healthcare research. Rather than saying, okay, have you used the gold standard, which usually means have you answered the question about efficacy, the double-blind randomized placebo-controlled trial, we can see that that is a gold standard for answering that particular question in the lower right-hand side of the circle here. It's really a mechanisms and validity question. But if you're interested in knowing what is the impact in a particular setting, even a proven therapy, when it's taken into a setting, may not work the way the clinical trial said. And so you have to use other kinds of methods, such as observational research, program evaluation, in those, such as up on the right corner, upper corner of this particular area. I'm going to skip the cost-benefit and pragmatic trial issues. Those are often what it comes down to when you have programs or interventions that are both equally effective in improving health. The question often comes down to feasibility and costs, and that goes into comparative effectiveness research. That you can't answer that question with a placebo control group. And then even after you do all of these things, the information that you get is still it's still an estimate. It's still inadequate. Even the best and most highly done randomized placebo-controlled trial is still probability data, and the clinical circumstances in which you may apply that can vary quite a bit. And so the question is, how can you translate that into different settings? Requires things like up on the left upper side of the graph, and that is through judgment processes like expert panels, things called appropriation methods, consensus conferences, this type of thing. We're not going to talk today about that process. It's a very important process because it allows you to fill the gap between the evidence and the clinical application to make determinations about appropriateness in the face of uncertainty, which you always have in healthcare. What we're going to focus on here is primarily the systematic review. It's looking at what is the current evidence in this area. We have other methods that are described in that middle circle that I'd be happy to talk about at a future conference or a future area if you'd like to. But I wanted to give you this context so that you can kind of see where the systematic review process fits, the kind of question that it answers and the kinds of questions that it does not answer, and the methods that fit with those that are the gold standards for those types of questions in those areas. And so I'm going to stop there and go on to the next slide. Oh, yes, I'm sorry. I'll go on to the next slide before I stop and turn it over. These are some examples of services that are frequently needed and used in the area of complementary and integrative medicine. The reason is those practices are often out there already being delivered. They're not necessarily things that were discovered in the laboratory. Some of them are, but most of them have come and derived from practice settings. And so the questions you often want to know, especially if you're a conventional policymaker or something like that, is what is it and how is it applied, and how do we collect data on it? And that uses a method that we call the claims assessment profile. It's part of our search service, which is systematic evaluation and research in healthcare claims. And it provides a detailed description and practice of the process and reported outcomes. The next question is that's part of the search effort is what current evidence is there, and that's the systematic review. And Cindy is going to describe to her the real method, which is the streamlined, rigorous approach for providing summary reports on a practice or a claim. And then finally, the expert panels I've mentioned to you is how can the practice be utilized. And these three methods often are used together because these three questions are often bundled together. In that people often need to know what it is, or they can't actually set up the right evaluation of it. They need to know what the current state of the evidence is so they can fill in the gaps. And they need to know, well, what does it all mean? Should we change policy? Should we change practice? What are the research gaps? And that's where the expert panels come into play. And so the long-term goal of this search process, the systematic evaluation and review of claims in healthcare, is to identify safe and effective and affordable healing practices or programs and to improve the individual and public health. And so I'm going to stop there, and I'm going to turn it over to Cindy, who is going to describe the rapid assessment process that are in there. And I don't know how many are on the phone or if we have the ability to take questions, but if so, be happy to have an interaction or respond to any questions before I turn it over to her.
Wayne, we've got about 10 people on, and I don't know if anybody's got questions. This is John. I think we're waiting for Cindy.
Okay, great. Well, hello, everyone. Thank you for this opportunity to share with you the methodology that we're using here at the Institute for conducting systematic reviews. So as Wayne shared with you, we have developed this framework called the SEARCH effort at Samueli Institute, which stands for the Scientific Evaluation and Review of Claims in Healthcare. And this kind of shows you the flow of our search services. And through this iterative, integrated process, you can be able to answer some of those core questions that we're showing on the previous slide. So first you have to be able to understand what the claim is, be able to describe it, and whether the claim is, whether it's feasible to engage in research. At the same time, we can be performing a systematic review to uncover and discover whether there's any current evidence to support the research claim. And then through this iterative process, you then involve various subject matter experts and stakeholders who take the reports gained from the evidence summaries and the claims assessment profiles to be able to bring in and make clinical judgments about the appropriateness and be able to translate the evidence into practice most efficiently. So I'm going to share with you the systematic review process that we use at the Institute, which Wayne referred to, we call the rapid evidence assessment of the literature, or the REAL process. So we created the REAL, the rapid evidence assessment of the literature, as a segment of search at Samueli Institute in order to provide a more rapid assessment process for systematic reviews that can be offered in a more quick turnaround time frame at a reduced cost, all while maintaining the rigor and integrity of a traditional systematic review. Our main goals for conducting REALs are to survey the literature, evaluate the quantity and quality, assess the strength of evidence and risk and benefit for treatments, identify gap areas, and be able to begin to suggest next steps for the field that we are investigating. And through this streamlined process, when integrated into the search, really forms the foundation for being able to determine appropriate next steps in policy, funding, research, and for making evidence-based clinical and field decisions on the use of the therapy or product that you're exploring through your research question. So as you can see here, these are our basic steps for conducting a REAL. And as you can see, they look pretty much like the basic steps of when you read a systematic review report. Obviously, you know, you formulate the clear research question all the way through presenting your results. So I'm going to share with you throughout this presentation ways in which we've taken the steps and streamlined the process to be able to offer in a more quick turnaround time frame, in a more rapid fashion, all while maintaining the rigor of systematic review to become transparent. So as we were developing this process for systematic review, we began to think about where are the obvious challenges in systematic review, and what are some ways that we can begin to fill some of these gaps and streamline the process to enhance the efficiency of systematic reviews so that they can be useful for making quick decisions for policy and other stakeholders. So I'm just going to walk through some of these challenges and ways in which we have tried to streamline them. So obviously, if you've ever conducted a systematic review, you understand that they're quite exhausting and cumbersome. And so rather than losing our minds and stacking up all these books, we now have worked with a company to be able to streamline the systematic review process in an online systematic review format system, where once you assemble your team and you conduct your literature searches, everything gets stored on this online system where you can share the whole process from your screening all the way through your data extraction with your online peers throughout the entire process of the systematic review. This really streamlines the process rather than taking notes on pieces of paper and losing things. Everything is managed within this online system. Another way in which we have streamlined this is by making really clear roles and responsibilities for systematic review. So as you can see here that systematic reviews are really a team effort. You can't really task a research assistant to go explore the literature around a specific research question that you need an answer for if you want it done rigorously and in an objective fashion that can be translatable. And so we feel at Samueli that there really needs to be this core team. So we have a steering committee. So the steering committee on any project helps us to define what the research questions are. They help to track the progress throughout the entire project. They approve different phases of our review and ensure that our deliverables are being met. Obviously, we have PIs. We have review managers who are really working with the PIs to ensure that the research questions are being devised. The teams are trained in the data analysis and data extraction methodologies, that things are going streamlined. We have medical librarians and research experts, reference management. We have subject matter experts who are designated from the steering committee and the PIs to join the systematic review teams to allow for their subject matter expert input. So if we're looking at a specific intervention and a specific condition, we may rope in various subject matter experts from different areas of that, both clinically and on the research side, to kind of walk through the process with us and then have a large involvement towards the end towards coming up with recommendations based on the results of the review. And obviously a statistician for understanding some of the data as reported, as well as conducting meta-analysis if deemed feasible. This really helps streamline the process because it allows for very clear roles and responsibilities and no hang-ups to occur because everyone has very clear roles and responsibilities for conducting these. Another challenge in systematic reviews is knowing what types of data to extract, ensuring that bias is not being introduced throughout your various phases of systematic review. So here is another area where our steering committee and our subject matter experts help work with our internal review teams to understand what population intervention control and outcome is framing the research questions, as well as providing their input around what are the important key elements that need to be extracted besides your key quality assessment criteria. What are those things that are important to the field, such as dosing, safety issues? What are the things that we want to extract from each of these individual reports in order to be able to make clear recommendations around next steps? And so our subject matter experts work with us to create rule books that go to the review team that can be used kind of as we call them our Bibles here for systematic review, so that people, the coders are extracting the data consistent in a reliable fashion and in an objective fashion, where they're not answering questions allowing their introduction of bias to become involved, but rather having very objective questions that are needed to be answered through these rulebook analyses. And this really helps to create more consistent Kappa scores, allows for the reliability and also the reproducibility when we finish a review, it's very easy to share this rule book with anyone outside the review that would obviously come up with very similar answers based on how we devise our rule books. Another challenge in systematic review is really losing sight of the research question. And so as you begin to pile through, hundreds of thousands of citations, your mind can allow you to kind of stray off on areas where things might seem more interesting than your specific research question. And this is where our team continually gets together at each phase, and we review the specific research question, make sure we're on track. The steering committee is constantly, reminding us of the research questions that are needed to be answered so that we stay on track. Another thing with our rapid evidence assessment of the literature is that we don't standardly contact researchers if something is not reported in an article. We take that article at face value. So, for example, if it doesn't mention safety, we're not going to get on the phone and call the primary author to say, did you guys collect this and just didn't have room to put it in your manuscript? So you'll see in our reports that we really make quite bold statements in our discussion pieces around our systematic reviews that in order to push the field forward around specific interventions or conditions that we're exploring, it really is, it goes on the basis of our researchers to be reporting those key elements that are needed to drive and make impact to translate the research into practice. And so through this process, it may seem rough that we're not contacting these authors, but we're relying on the authors to provide the data that's necessary in order to translate the research. And so here, this goes towards, reporting of statistics and describing power calculations and how things were done in a transparent way so that we can document that in a way that can be useful for translation. So here is a slide talking about synthesizing the overall literature pool. So once we finish with our data extraction according to the individual studies for the systematic review, we then take it one step forward to look at the overall literature pool and reflecting on the research question to be able to come up with some recommendations and understanding about how the research question can actually be answered based on the summary of the individual studies collected. Here is what we call the grading of recommendations, assessment, development, and evaluation. And this is actually a working group that's used quite often. We've kind of modified some of the criteria here that we use, but basically it's looking at the individual studies to come up with what is the overall number of the studies, how many participants are there, what is the overall effect, and power to produce an effect based on your individual questions. So if here we're looking at acupuncture across various components of what is called the trauma spectrum response. So we looked at headache, chronic pain, sleep disturbance, depression, anxiety, etc. And so we wanted to look at, for acupuncture, what is the effectiveness as reported in the literature for each of these various components that makes up the trauma spectrum response. And so the subject matter experts come in with us with the steering committee, and we look at the individual studies that are extracted, and we lump all the studies on headache per se for acupuncture and look across all those studies and how large are those studies, and be able to come up with how confident are we in those results. So Are the results across those studies showing consistent results? Do they have similar effect sizes? Is the interventions and how they're being conducted similar enough to group together? Data summary score for them. Are they reporting safety? And based on the safety that is being reported, can we take that with the confidence to be able to come up with a recommendation about whether we would say it would be appropriate to use in practice or not? So this is one step forward, and simply reporting that more research is needed. We're actually trying to come up with some very realistic recommendations about how you can move the research forward. So here's some of the recommendations that came out of this report, and you can see that they're pretty specific. So here's the gaps that we found in our systematic review that we put out in our discussions about what needs to be done in the future in order to push this field forward towards implementation. So we noticed that dosing is inconsistent, which we notice in many of these reviews in integrative medicine. So in order to begin to take the synthesis of systematic reviews and be able to push the field forward to understand what is the next step that's necessary, do we need to conduct a future randomized controlled trial? Do we need to do more program evaluations, or do we already know that the evidence is there and we don't need any more research? So these types of recommendations allow one to begin to strategize what are the gaps in the area as based on the literature that currently exists, and how do you begin to fill those gaps? So here we have dose. We say, safety was not addressed well in the majority of these studies. If we want to make recommendations about acupuncture across the TSR, we need to understand safety first, right? It seemed that many of the clinical trials were quite small, and so many of them were underpowered, and even when combining them across those that were similar enough, it seems that perhaps combining funding streams and strategizing between teams that are interested in acupuncture may be a good next step towards creating a more robust randomized controlled trial that will help to be more robust in addressing some of these areas that will hopefully show to be more effective. So many of these gaps can help to bring, you can strategize them with your subject matter experts and steering committee to begin to think about ways in which you can fill the gaps and translate them into either future research agendas, or if it's feasible and ready to begin to talk about ways in which they can be used in application, then we turn into what is the next step of the search process, which is the expert panels. So based on these gaps that we identified throughout the systematic reviews through the real process, we can then bring together appropriate stakeholders that will be involved in these expert panels, where we either look at research expert panels, we look at clinical application panels, or implementation panels.
Yeah, let me give you an example of that. So putting the expert panels together is a key component of this, and it allows for multidisciplinary input that pulls together the core issues of utilization and methodology. For example, the series of reviews that Cindy just showed you in acupuncture around the trauma spectrum were because a core policy committee within the military wanted to know what is acupuncture or CAM components, and we have other reviews and different other CAM components also. What are ready for prime time? What should we put into our practice? So it's not just about looking at where are the gaps in the research, but also what is appropriate. In other words, what's already deemed to be safe enough and efficient enough to deliver that they ought to be able to implement them. And after this particular reel, for example, we did another one on pain. The primary committee then said they picked out two that they said were ready for prime time, meaning they were ready to actually implement widely. So this meant that they were not going to stop doing research on it, but the research was about health services research. It was about delivery. And so now it was truly about translating this into an entire system and adopting those things within the system. And they said we don't really need to do a lot more efficacy research around those particular practices. So it allows you to stop this sort of endless cycle of, well, we don't have enough research. We need to do more, and actually look at what's ready to move into practice.
Yeah, so the pain review that Wayne's talking about is we looked at self-care practices that can be that you can learn through a specific training, and through our review and expert SME involvement, we were able to rank based on the literature, which modalities were most ready for implementation. And we were then able, from the gaps we identified in the literature reviews, we were able to identify what are the factors that are needed to understand more better to begin to implement, and how would we go about applying an implementation in those areas for those populations.
So a large system, a healthcare system, for example, that's trying to say, well, which of these practices should we make a part of our system? This provides a pathway and a process to do that. I'll be going over next week to the Netherlands that has decided they need to figure out how to put more integrated medicine into their entire country's healthcare system. And this is the kind of process that they're going to need to use in order to identify the first ones to begin to adopt. Okay.
Great. So this slide just shares with you some of the utilizational examples that we've used the real process, looking at various programs, practices, and products that we've explored in the area and within our mission at the Institute. And then, as Wayne mentioned earlier, we do offer workshops, usually twice a year, where we share the tools for conducting these systematic reviews in a more rapid fashion. It usually consists of a 3-day workshop where we have various instructors, and we offer participants to come with either, a research idea that they're interested in, or perhaps a systematic review that they're already working on. And we delve through the in-depth processes and detailed steps of conducting a systematic review from question development all the way through publication, and offer several breakout sessions and mentoring throughout the 3 days, so that you can really get your hands wet into each of the individual steps needed to conduct the systematic review. We also see this opportunity through our workshops as a way to, credential others in this systematic review process, so that we can work together through various avenues that or opportunities that may come about, so we can work collectively in a way where we're sharing the methodology in a streamlined way.
Okay, is that it? Thank you very much. That's all we had. And, if there's still time and people have questions or comments, I'll be happy to spend a few minutes addressing them.
Any questions?
I have a question. One of the, I think, criticisms of systematic reviews, particularly in CAM, is that the trend in doing systematic reviews has been to basically consider anything that is not a randomized controlled trial lower quality. How do you recognize that? I guess what I'd like to know in the real methodology, do you include other types of studies besides randomized controlled trials?
So I think it depends on the research question. So standardly, we conduct with the real process, if the research question is feasible, we will just look at the randomized controlled trial. And by doing that and understanding where the gaps lie in the literature and the data that you glean from the results of the randomized controlled trial can help you understand whether a future research agenda is needed with a randomized controlled trial or perhaps a different study design. And so those gaps that emerge can help you understand what research agenda needs to be carried forward next. But if a research question is developed and it's believed that with the SMEs and the steering committee that it is essential to understand the literature not only provided through randomized controlled trials but other types of study designs, there's various tools for evaluating the quality of many different research designs, and we share those at our workshop, and we have certainly conducted systematic reviews where we do evaluate different types of study designs.
And are those criteria similar to, say, the Cochrane weighting system, for example?
Well, the Cochrane standardly looks at only randomized controlled trials. And they use, I think it's a 5-point criteria, which we certainly use as well sometimes. But the criteria has to change based on the method, right? So, yeah.
And there are a number of published, some good, some not so good, evaluation criteria for different types of methodologies. Observational studies, qualitative research, case studies is an evolving one that you've probably seen a lot of with David Riley's journal, looking at the criteria for case studies and things like that. So there's actually a list, and actually at the workshop you learn about those different types of approaches that can be utilized to judge the quality of different kinds of methods.
So we've looked at various different quality criteria scoring systems and actually conducted some reviews on which ones are better than others that we feel. But I think the importance of all of these quality criteria tools that you find in the literature is that they're all very subjective, and whoever gets their hands on them is going to interpret each criteria question differently. And if you have different reviewers working together on a review, this is when it creates a challenge, because you may subjectively interpret something one way, whereas your colleague interprets it another way. And so again, this goes back to the importance of rule books and making sure that you're objective and you're reproducible in whatever criteria you use, that it's understandable and translatable.
Wayne, I have a simple question. This is John Weeks. It's kind of a fun one. So you started off by talking about the IOM process with which you were involved and the costs they went through. What do you suppose the real methodology might have saved them?
Good question. Well, we've actually estimated that, and you could probably, again, depends on what you're trying to do. You could probably do this for probably at least less than a third of that, maybe even a fifth of what they do, and pretty much come out with the same information. Now they do other things. They they do a lot of PR around their aspects. They send it out they write a book generally report to answer the question, because they usually do this in response to a specific request, usually from a government agency, to answer a very specific question, so they have very narrow focus. And then they also exclude, once they've picked their expert panel outside, they sort of exclude the requester, which sometimes results in a report that doesn't really help the requester that much, because they do it in an attempt to remain independent and objective, which is good for that, and they're very rigorous about conflict of interest and this type of thing. But it removes the iterative process that helps you get at the practical applications of the research itself. And so we actually don't remove, say, a funder from it. We'll let them be part of a steering committee, but we have ways of managing the bias processes and the publication processes, so there's both input and, we believe, rigor at the same time.
That's good.
So the steering committee they oversee us, but they are not involved in the review at all. The subject matter experts are different from the steering committee in that they are involved in every phase of our review, but they're not the ones extracting the data.
Exactly.
They can allow for their input into it.
And the trained reviewers, which have all been trained up to a particular Kappa standard, validity standard, are the ones that actually do the data extraction and actually make the, pull the information out and say, here's what the current science says in terms of quality and outcome issues. Mm-hmm. That's not done by the experts.
Yeah.
Thank you.
Any other questions? And I really enjoyed the presentation, and Dr. Jonas, I loved your slide of the circle and the different types of evidence and the studies related to them. And so I did pull your second edition of the text you recommended just to review the evidence house, and I do see that you have kind of the beginnings of that circle model in Figure 1.3 of your second edition. So it was I really enjoyed seeing that that way of presenting different studies related to different types of evidence needed. So thank you both for what you've done here and for speaking with us. Any other questions? Don, do you have anything to add?
I've got nothing. I, too, enjoyed seeing the evolution of the evidence house there, Wayne. It's been a great contribution to this whole dialogue. On the call is Deb Hill, who's a member of our staff now, who came through Audie's Georgetown program and is helping us with what we call our Project for Integrative Health and the Triple Aim. And so we're particularly interested in helping to support decision makers in that area. And I guess I have a question. We're over time here, and I suppose people have left if they need to, but I'm wondering what you're finding out in the world as in terms of willingness to of decision makers to move into more ambiguity if they believe they have a fair sense of the safety of an intervention, have a strong sense of that the patient experience is a good one, and have a pretty strong sense that the cost is going to be minimal and may even be cost-saving. Are you seeing people being interested in exploring perhaps earlier than they might have 10 or 15 or 20 years ago?
I think there's absolutely is in our experience. I mean, again, I'll give you the example of the DOD and also in the VA, but there's other outside organizations, other organizations too, health insurance companies and hospital systems that are started to step up to do this, where those kinds of criteria are exactly the kinds of things that they're beginning to ask and put into evaluation processes in making clinical decisions. So, for example, in the CAM and pain process that Cindy did not show you but is related to the acupuncture one in the An expert panel group that put together and looked at the grade issue then said, because of the safety and simplicity of delivering these components, these things are ready for prime time. And we do not need any more evidence in the lower left hand of the circle, which previously was at the top of the hierarchy, right? And have said, in fact, we're ready to implement this. And what we need is the health services research to know the costs and the delivery and the training quality criteria and this type of thing. I mean, these are the kinds of things that also, I think, have been discussed or should be discussed in PCORI, in the Patient-Centered Research Outcome Institute, whose goal is to bring the patient perspective directly into the research dialogue and discussion. And when you do that, you get a very different set of types of information and strategies that you need. And so I'm hoping that PCORI will shine a light on the need for a multi-component or multi-method approach in a pluralistic therapeutic environment.
So what is also fascinating about the pain review that Wayne spoke of is that some of the modalities that, you know, there appeared to be no evidence for were some of the ones that were most excitable about from the patient side. And so just because the systematic review showed that there wasn't good evidence for that, that's where, you know, these expert panels are very helpful, because you're not simply dismissing that modality because there's no evidence, but perhaps strategizing on how to build the evidence to be able to promote it.
And that's a second step. That's called an appropriateness panel, which we did not discuss today, but what it does is it takes the context and clinical scenarios and it makes a structured judgment process about the appropriateness that incorporates those kinds of safety and delivery and preference principles that you've just referred to.
Yeah. And the entire thing is going to be produced in a supplement to pain medicine, and it should be available in April, if anyone's interested in it.
Thanks. A little follow-up that's actually a question that was in part of our mixed message discussion. I'm wondering if you're seeing people who are kind of taking the triple aim as a guide in research modeling and basically saying, if I'm going to look at this, I'm going to ask questions that will help answer all three of those triple aim questions. Are you seeing a move in that direction at all?
You mean in terms of in single studies?
Yeah.
Yeah, most of the triple aim language and attempts come into an evaluation component within settings of delivery, primarily to do quality improvement rather than to make decisions about and to help them make decisions about what they do and what they don't do. So it's a different context. And so it's done primarily not for, it's primarily done to try to track current practices to see if they're being applied in a way that meet those criteria. Now, usually in making a decision about what is acceptable, they don't necessarily use the triple aim to make the decisions to what goes in there, but they use it as in an evaluation context through observational research, which I think which I think will be a method with increasing ability to collect the data easily and continuously around outcomes and practices. I think as that sort of big data approach evolves, we will see decisions around healthcare policy that used to require randomized controlled trials replaced by that type of big data observational research. And I think that's where the triple aim and other criteria will come into and replace sort of the hierarchy using on the circle what I showed you, which is really the observational types of research, like practice observation.
But do you think you'll see this evolving for the initial I mean, obviously with integrative health that's been on the outside looking in, I'm wondering if they'll be looking at the triple aim as an inclusion process and not just as a review process.
Well, I think that the triple aim is already an important factor in tracking practices in terms of their quality and delivery components. So, to the extent that integrative practices can demonstrate that impact on the triple aim simultaneously, that is clearly going to be a criteria that will gain some attention. I think that there will still always, well, at least initially, there'll be an element about, well, does this matter outside the context? So some type of comparative component or comparative effectiveness component is likely to be required for a while.
Thank you.
Okay. Well, thank you. It was a great pleasure to talk to you all and to see the group in action, and look forward to working with you again sometime.
Thank you very much, Wayne.
Thanks so much.
Thank you.
Thank you very much.
Good work.
Thank you.
Bye-bye.